My name is Elaine Gonzalez. I'm the community educator here at the Breast Cancer Resource Center. We're honored to have with us today Dr. Andrea Milbourne. Dr. Milbourne is a professor and head of the section of general gynecology in the Department of Gynecologic Oncology and Reproductive Medicine at the University of Texas MD Anderson Cancer Center. Welcome, Dr. Milbourne. Thank you so much for being here, and I will turn it over to you.
Hi, good afternoon. Yeah, it is afternoon, so it is good afternoon. As Elaine said so kindly, my name is Andrea Milbourne. And to give you a little background about myself, I came to MD Anderson about 20 years ago with the idea of setting up a gynecologic practice for women with cancer who had, as some of my colleagues put it, quote unquote, down their problems. We have now sort of blossomed into 2 full-time, 1 half-time, part-time gynecologists. We have 2 reproductive endocrinologists who focus on what's called oncofertility, so fertility preservation in women with cancer. We have a bunch of preventative clinics, and anyways, we are busier than ever. And one of the things that has come up in both my practice and my colleagues' practice is sex and intimacy after cancer or during cancer, and what do we do and how can we go about this, and what is available for women. And I can tell you 20 years ago there wasn't much available, and sadly it's not that much better now. But I'm hoping that by giving you a little bit of background about this, and then Elaine had sent me some questions prior to this when we were planning this. And so I just sort of wrote out these questions and my answers to them. I really want you to feel free to chime in. And, if something comes up when I talk, you want to ask a question, just put that questions in the chat box and we will try and get to it. Zoom is very lonely because literally I don't see your faces. So you might as well be amorphous little blobs out in cyberspace. And I know it gets difficult to listen to some erudite professor hold forth about stuff. So I'm going to try and be as engaged and as engaging as possible so that you guys get something out of this. Before we launch into the first slide, I just want to say I don't get any money for this, and I'm not sponsored by any pharmaceutical companies. I will mention some pharmaceuticals, but they'll only be FDA approved pharmaceuticals. And then next slide. So first of all, you are not alone if you have questions, if you're afraid, and if you're ashamed. And if you think this might be trivial, because, and I've heard this from a lot of my patients, after all, I'm alive, and should that not be enough? Also, sexual dysfunction in women is very common, even in the women who don't have cancer. In a fairly old article from 1999, among US women, 30% of women between the ages of 18 and 59 lacked interest in sex. 25% in the same group were unable to achieve an orgasm, and between 10 and 20% had pain during sex. Sadly, the landscape does not look too much different today. If anything, some of this stuff may have become exacerbated with the advent of social media, where everybody is beautiful and perfect looking and has the perfect life, because nobody is ever going to post, boy, I had a sucky day today. Work sucked. I went home. The kids were sucked. My husband sucked. And then he wanted me to put out. And I just didn't feel like it. So, what you usually see on social media is, oh, we're so happy, everything is great, and we have the best life possible, and I'm so grateful. Remember, everybody embellishes that. Next slide. So sexual dysfunction, although, as you saw, was present at least in 1999, so like 20 plus years ago, and probably much longer than that. But nobody talks about, there's two things you're not supposed to talk about. And well, actually, I guess three things that you're not supposed to talk about in polite company: sex, money, and religion, right? And I could add another one, which is pooping, bowel movement, because everybody does it, but nobody ever talks about it. And I tell my patients when they're embarrassed to ask about sex, I'm always like, you know what? Everybody wants it. And those who don't spend an inordinate amount of time in thinking about it. So you are not alone. It has now, however, been added to the latest DSM-5. And the DSM-5 is a diagnostic, it's called the Diagnostic and Statistic Manual of mental health. And essentially it classifies and codifies mental health disorders. And so there were 3 in women that have been added to the DSM. One is female sexual interest arousal disorder. The other one is female orgasmic disorder. And then there's genital pelvic pain / penetration disorder. The first one is also called hypoactive sexual desire disorder, or shortly Hsdd. And we could have fun with all kinds of ways to translate these acronyms, but we'll save that for another time. So if we are now in the DSM-5, does that mean we're crazy? Well, possibly. However, this also opens up the area to research and legitimacy, right? As you may or may not be aware, women have been, up until probably about 10, 20 years, routinely excluded from research studies because, those pesky hormones, and we get pregnant and our mood is not the same every day, and our hormones are not the same every day, and things change over our reproductive and then post-reproductive life. And so, in other words, we were kind of a bother to science to study our reactions to drugs. And I'm going to digress here a little bit. What that has led to is that we just recently have learned that heart attacks in women present differently than in men. Also, women are not smaller sized men. Excuse me. And medications are metabolized by our bodies and our livers differently. But this is literally just something that we have learned about formally, I should say, because a lot of us in medicine had seen that with our own eyes and had suspected these facts for a long time, especially if you're of the female persuasion. But this has not been, really studied until there was an impetus from the NIH to say, wait a minute, maybe we need to look at this, because we can see, at least as far as heart attacks and cardiovascular disease is concerned, that it does affect women, and women appear to be doing more poorly than men if they have these events, because maybe we're not recognizing what their symptoms are. So, as I said, this adds legitimacy, and it hopefully allocates some funds for people to study this. Next slide. So, what do we have as treatments? And as you can see, sadly, not a lot that actually works. Next slide. I'm going to talk briefly about medical options. The first one is an FDA that's been around a little bit longer, and it's an FDA-approved medication for hypoactive sexual desire disorder, Hsdd, in women who have not gone through menopause. Oops, I'm sorry, that I should not be in there. The medication is called flibanserin, and the trade name is Addii, or Addii. It's a repurposed antidepressant. It needs to be taken daily. And in a study of about 1,000 women, where 500 women were allocated to take these tablets, 100 milligrams at bedtime every night for 24 weeks, versus 500 women who just got a sugar pill at bedtime every night for 24 weeks. It appeared to have increased the number of satisfying sexual events from 1.5 to 2.5 over 24 weeks. And this is per month over 20. So this is 1.5 to 2.5 satisfying sexual events in a month, in a month. In a month's duration. So I just see somebody in the chat, but I took Addy for 6 months. It did nothing to my libido. It's a great sleep ad though, but my insurance doesn't cover it. So I wasn't going to stick with it just for sleep. Well, and there you have it. Thank you for sharing that. And that's sort of what I think the gist was of this, of a lot of this. We used to have a psychologist on our team whose specialty was sexual desire disorder and sexuality counseling. And she said, essentially, flibanserin was kind of a bad antidepressant. And so, but they found that it depressed sexual desire less than other antidepressants. One of the big side effects of most antidepressants is that it depresses sexual desire. And so flibanserin didn't depress it as much. She was not very impressed with how it worked. And I just realized I think I can control my own slides. Nope, I thought I did. Okay, never mind. Next slide. The other FDA-approved medication is Melanotite, and it goes under the brand name of Vyleesi. It is an injection, and it needs to be injected under the skin 45 minutes before the woman wants to have sex. It's also FDA approved for Hsdd, hypoactive sexual desire disorder in premenopausal women. It does not contain hormones, and it works centrally on the brain, because most people actually believe that all these things originate in the brain. As I tell my patients when they say, well, I just don't want to do it. And I'm like, yeah, it's sex for women happens more between the ears than between the legs. But in one study I saw, it was about 20% effective in women who took the injections versus 17% in women who received the placebo in eliciting satisfying sexual events. And I apologize for using this jargon. There was this whole sort of approved words and jargon for measuring sexual desire and sexual events and sexual satisfaction and personal satisfaction. This is all very much sort of from the psychology, psychiatry literature. And I just saw somebody asked, are these contraindicated in postmenopausal women or simply untested in that subgroup? So what I was seeing is A, it has not been tested, and B, it's contraindicated. There is, with Vyleesi especially, there is, and flibanserin too, there's specific precaution not to prescribe it to geriatric people. And lastly, sadly, there's no Viagra for women. So there is no one drug, one pill, one injection, one anything that works reliably for women who have decreased libido or decreased sexual desire. Next slide. And this is possibly because this is what our brain looks like, and this is what a dude's brain look like. And actually, I was looking for a lot. I had a much better representation of how complex women are and how simple men are, but this is the best I could find. Next. Oh, so, however, all kidding aside, right? Aside from all the other concerns that we bring into the bedroom with us, after cancer, there are additional concerns. Looks and often the body image is different. There are the hormonal changes. And then there is just the whole thing of, could the cancer be coming back? Is this headache that I'm having, is it just a headache, or is it is it a sign that it has metastasized to my brain? Oh, this backache that I'm having, is it because I lifted something wrong, or is there a little cancer lurking in my back? And then cancer changes you. I don't think anybody comes into a brush with their own mortality and comes away from that unchanged. So somebody asks, isn't there a difference in postmenopausal and geriatric? Yes, there is. I'm not exactly sure when geriatric begins. I want to say it's over 65. But these medications are specifically approved for premenopausal women. And it could very well be that it has not been tested. I'm sorry, I did not look into that closely. Next. So I'm going to start with some questions. And hopefully I will have, these were the questions that were handed into Elaine or sent to Elaine before the start of this webinar. So if something resonates with you, let me know. Yeah, and then somebody just said, I'm postmenopausal, age 33, so definitely a difference between geriatric and postmenopausal. Yes, you're totally right. Absolutely. And you're right. So that was kind of funny. Thank you for pointing that out to me. And I should know that, since I've made many a woman postmenopausal before they were geriatric. So somebody had posted, I am ER/PR positive. What safe options do I have to help with libido? I'm young and it went away almost immediately during 2 years of treatment. Also, my wife is in natural menopause and having the same struggle. As you saw, there is not a lot that we have to help out with libido and sexual desire. There are some over-the-counter supplements that appear to have some benefits, and those are L-arginine and citrulline. And then sex therapy may help to find other ways of being intimate, or for dealing with the barriers to intimacy, right? One of the things that we see is that if somebody goes through cancer treatment, for however long it takes, for that time they become the patient. And so the roles of wife, lover, partner become blurred, and one person becomes the caretaker of the other. And so to get back into, okay, I'm better now, you don't have to take care of me anymore, become very, it becomes difficult for one of the partners sometimes to go there. And yeah, there are a lot more people saying, I'm postmenopausal due to taking medication. It doesn't change why you're postmenopausal, whether you're postmenopausal naturally, through surgery, or due to taking medication. Postmenopausal is postmenopausal and has the same effect on your brain, on your body, and everything else. Women who are taking these goserelin, Zoladex injections will have hot flashes as much as women, or as little as women who've had their ovaries removed or who have gone through natural menopause. There is some taking women with breast cancer aside a little bit. There is evidence that menopausal women who are on sufficient estrogen replacement or hormone replacement, if they're giving low dose testosterone, that helps with libido. Again, unfortunately, there is no one size fits all. And since there's been this sort of somewhat negative result of hormone replacement in postmenopausal women, it is unlikely that anybody is going to get approval to study testosterone supplementation in women. We do know that it works for a lot of women. subsequently to that, there sort of sprung up this bioidentical hormone replacement or pellet injections hormone replacement. I've had some patients who've said it made them feel better. It also had the side effects of causing abnormal uterine bleeding. One woman developed male pattern alopecia and hair growth on parts of her body where she didn't want to have any hair growth. Just a big caveat, these bioidentical hormones or natural hormones are not that natural because they still come in a vial, in a bottle, in a pill, or in a cream. So it's not like it's something that grew on a tree or was produced by your own body. So they still have the same risks of the regular hormone replacements. Somebody's asking, I am ER/PR positive. Is low dose testosterone safe? I heard that testosterone breaks down to an estrogen. So if I can digress real quick, the reason nowadays a lot of young women with breast cancer are placed on ovarian suppression, whether that is surgical or by an injection, by a monthly injection, is so they can get what's called an aromatase inhibitor. And the aromatase inhibitor inhibits transformation of testosterone to a weak form of estrogen in our fatty tissue. Everybody has this enzyme in their fatty tissue. Even men have this enzyme in their fatty tissue. So the more fatty tissue you have in your body, the more of this enzyme you have, the higher your level of this weak estrogen is. And estrogen in general, of course, on breast cancers can work as a growth hormone, but also on the uterus can work as a growth hormone. And growth hormone, when somebody's growing, is okay, but when you're done growing, you don't need growth hormone anymore, because then that can lead to cancer. So we don't know. The short answer, or that's sort of the long answer, and the short answer is we don't know if low-dose testosterone is safe in women with estrogen progesterone receptor positive breast cancer. There is also the concern that it may raise cholesterol and cause so-called hyperlipidemia. In other words, have a negative effect ultimately on cardiovascular health. Next slide. So somebody else asked about what are effective ways to communicate my issues and needs with my partner. For example, body issues, libido, sex play. One thing I have to say, these discussions should ideally happen prior to anybody having surgery or even starting treatment. They should definitely happen outside of the bedroom with everybody dressed and possibly with the help of a therapist. I think oftentimes, however, because cancer is so scary, these other things are not discussed or sort of briefly discussed, or are, oh, we can send you to da-da-da-da-da. But then there is time and money and other commitments that come in often into this, and the treatment takes precedence over everything else. I've learned in my practice that women often have significant grief about losing body parts or even just having cancer. It feels to some women like their body has betrayed them. And, you know, whether we like it or not, in public and in the media and really out there, what sort of distinguishes from the men is the fact that women have breasts and men don't. I mean, there's a whole bunch of other things, but that's sort of the outside obvious thing. If you see somebody with breasts, you sort of automatically think that that's a woman. And, you know, no matter how we feel about our breasts, from the time we go through puberty, we have them, whether we want them bigger, whether we want them smaller, whether we want them perkier, whether we want them, who knows what, right? I mean, we can, as women, we can pick apart our body parts and find something wrong with them, even the most perfect person. And so when one of those body parts, quote unquote, turns on you and has cancer and tries to kill you, that feels like a betrayal on a very deep personal level. And oftentimes, as I see with some of my patients during treatment, there's some awareness about this, but it really happens more once the treatment is over, once they're not so busy anymore. And oftentimes these feelings really have to be addressed and worked through and acknowledged. Because just being cancer-free is often not the end all and be all. And changes to the body and to the mind often have far-reaching consequences. Somebody said just now she's 33 and is in menopause. So that's kind of not quote unquote normal, right? Women, the average age of menopause, natural menopause in this country is 51. And for some women, perimenopause starts in their 40s. Even if you're menopausal in your 40s, that is sort of still considered okay and normal. But to be 33, for a lot of women, especially professional women who have put their life on hold, so to speak, to have like the perfect job, the perfect partner, the perfect everything, is there ever? That's the time they start thinking about, well, maybe now we can have a family. And then to be told, well, sorry, we're going to have to cut all this short because you have breast cancer. That can be very difficult to process. And obviously, because breasts for a lot of women are sexual organs, you chop them off, you change them, they don't look the same, they don't feel the same. There is a lot of body image and loss of associated with that. So, this is a very long-winded answer to what are effective ways to communicate my issues and needs with my partner. It may need help with a therapist. It may need help with somebody, a third person who's not involved or intimately involved with the person, because of course, all the other stuff is going to come up. Maybe the woman needs therapy, maybe the partner needs therapy separately, and maybe they need therapy together to work through some of these issues. Because it is very difficult to go through this physically, mentally, emotionally, and lastly, let's not forget another important aspect, financially. So I think all of these things weigh in on, what should be a pleasant and intimate time for people, but we're not separate little boxes where today this is my sex box, I only let that out, or no, this is my money box, I only let that out on certain hours, or this is my I want to play box and I only let that out on certain hours. We're all of these different parts within us. Next slide. And I think some of you may already be familiar with this. How will having my ovaries removed affect my sex drive? So removing the ovaries means, well, all of the female hormones that are being produced by the ovaries are gone. So that means immediate menopause, and it may affect sex drive negatively. However, for some people, feeling free from the fear of recurrence may have a calming and freeing effect. It also means you will not be able to get pregnant anymore. For some women, that is totally freeing. For others, it's tragic. One of the bigger issues I see as a subsequence to having ovaries removed, whether surgically or medically, is vaginal dryness and pain with sex. I think importantly, before you embark on this, talk to somebody about the pros and cons of removing the ovaries, as well as why do we want those ovaries out? There's multiple reasons. Obviously, if somebody is a carrier of one of the BRCA hormones, there's an increased risk of developing ovarian cancer. And for some of those women, it may be life-saving to have these organs removed. For others, they may have metastatic estrogen and progesterone positive breast cancer. And in order to receive the most effective therapy, their ovaries need to be repressed suppressed. And their oncologist does not ever want their body to see a smidge of estrogen ever again. So there's different reasons. And I think all those reasons should be explained and looked at, as well as talking honestly about what are the sequelae of this? Like, what does that mean for me, that my ovaries are going to be removed? I can give you a little story about one of my patients that I saw the other day, who's under the age of 40, and is on goserelin of the Zoladex injection, and is going to start on an aromatase inhibitor. I think she's going to start on letrozole. And she was sent to me to have her ovaries removed, to talk about having her ovaries removed. And so, we talked about, she said the injections don't really bother her, because she's on some other medication that she has to come in for once a month anyways. And she has been doing fairly well with these injections, and hasn't noticed any negative side effects. So when she said, should I have my ovaries removed? I asked her, well, how long are you supposed to be on this medication? And she said, probably about 5 years. So she would be in her early to mid 40s when she stops, or maybe 10 years, depending on what we know in 5 years. So I told her that we have some pretty good studies that look at what happens to women who have their ovaries removed. And these studies look not just at women with breast cancer. These are women who had their ovaries removed for all kinds of reasons, not just for breast cancer. And looking at these women, it was found that there was an increased risk of dementia, obviously bone loss. There was also an increased risk of death from, as they said it, all causes, and an increased risk of heart disease. Can we ameliorate some of those factors? Absolutely. Lifestyle is a huge determinant in heart disease as well as dementia. Bone loss is a little bit more difficult to just address with lifestyle, but weight-bearing exercise and weightlifting and taking calcium and vitamin D helps with that. The bigger issue comes with vaginal dryness and pain with sex, because if you are truly determined to remove every smidge of estrogen, how much more estrogen are you supposed, how are you supposed to deal with vaginal dryness? Elaine says we have about 10 more minutes, and she would like to answer questions in the Q&A box. Okay. Can we look at the next one? At the next slide, because I think that may be helpful. I think this is another helpful slide, and this is as far as hysterectomy is concerned. Somebody was asking how malleable a vaginal cuff is after a hysterectomy. The truth is, the vaginal cuff doesn't change in response to a hysterectomy. The vaginal cuff changes in response to hormone, or the vagina changes in response to hormone. A baby's head can pass through a vagina, so we know a penis will fit. And somebody said, I personally had concerns about whether my husband would fit and how much pressure it can take to sex. So as long as the cuff is well healed, which is usually within 3 to 6 months, the risk for cuff dehiscence or the cuff opening is very unlikely. And yes, vaginal orgasms are possible, clitoral orgasms. And then my question to you, does the mythical G-spot even exist? So somebody posted a question. I am ER/PR positive, 3 years post-diagnosis, over age 50s, ovaries removed and taken anastrozole. My oncologist said absolutely no to low-dose vaginal estrogen. My friend with ER/PR positive 1 year post-diagnosis has a prescription from her oncologist for the cream. What is the standard of care? Are there sufficient safety studies? Okay, so there is no standard of care. That's the short answer to this. there is one study that's a poor study that was done with 25 micrograms of ethinyl estradiol in a tablet form, in a vaginal tablet form. This is not available anymore. This is not available anymore. The highest dose vaginal pill preparation we can get nowadays is 10 micrograms of ethinyl estradiol. There is also estrogen vaginal cream, which has 1 milligram per gram of cream of either ethinyl estradiol, or if it's the trend name for that one is estrase, or if it's Premarin, it's conjugated equine estrogens, and it has 0.625 milligrams per gram, depending on the dosage of it. So to get back to the study, there was this study that was done on 7 women, and they were given 25 micrograms of ethinyl estradiol vaginally for 12 weeks. And the way it's supposed to be given is 1 tablet vaginally every day for 2 weeks, and then every other day or every third day, or, however often the woman needs it, but less than once a day. And they found that in all of the women, the estradiol bumped a little bit, but it was still in the postmenopausal range. So nobody all of a sudden went into the quote unquote normal premenopausal range. Everybody remained in the postmenopausal range. The sad news is they broke the study off after 12 weeks. We all know we don't just use something for 12 weeks and then stop. But there were no, there's no long-term studies. So we cannot long-term say that it is safe. All we can say is with the nowadays lower available vaginal tablets, the 10 micrograms ethinyl estradiol tablets, it is unlikely that there is a significant increase in serum, meaning total body estrogen, that can be measured at all. But it does help with vaginal dryness. Somebody said their oncologist was okay with DHEA. We also don't know if DHEA works. I don't know. There are no studies that says DHEA is safe when it's given as a vaginal preparation, because our body is very adept at converting absorbing vaginal medication and then converting them into other hormone substances. DHEAS is a precursor for many sex hormones, and so it could theoretically be converted to estrogen. Do we have any other question? I think, Elaine, you had some question. You had some question that somebody had sent you.
Yes, there are a few questions in the Q&A box.
Yeah. You know what? I'm not in the Q&A box. I'm in the chat box. Sorry. Okay.
Are you able to see those?
Yeah. So somebody's asked, I have been very proactive post HUR2 treatment, which effectively medically takes all your estrogen away. Actually, Herceptin does not. What happened to the question? The question went away. Huh. I was just answering the question. Now it's gone.
Okay, it's in the answered box. I can read it for you. She said, I've been.
Oh, here. Yeah. So I've got the Diva treatment and have done pelvic floor therapy. Sex is still painful and certainly not enjoyable. Will arousal ever come back? How long after treatment, if you're still premenopausal, is there anything else that you can do? I am not familiar with the Diva treatment. Pelvic floor physical therapy certainly can help. Lubricants and vaginal moisturizers are very helpful. And the thing with arousal is difficult, right? If something hurts when you do it, why would you want to do it? And if you don't enjoy when you do it, what makes you want to do that, right? So if you're still premenopausal, how long after treatment will this come back? It should come back fairly quickly. The concern is, however, what are the underlying issues that may be there? And I'm certainly not saying that you're crazy and have other issues, but it may be helpful. It may be helpful to talk to somebody at that point, to talk to a sex counselor, a sex therapist, and to talk through what is going on. Let's see. What about testosterone? So somebody's asking, what about testosterone for libido? That's what the sexual health therapist has me trying out. I've been on about it for 2 months and haven't seen a change, but I was told it may take a while. I'm also ER/PR positive. So yeah, you should never take oral testosterone. The topicals, it depends on a number of factors, because as you may have seen, in the studies, the response to these, whatever we give, are all over the place. Some women respond to testosterone. Even in postmenopausal estrogen replete women, testosterone only helped in about 30%. So it may not just be what's going to work for you. And again, with even topical testosterone, there is the concern how much of this is going to get converted to a weaker form of estrogen. So the answer is we don't have a lot of good answers. But if after a couple months it hasn't worked for you, I'm not sure that it is going to work. Somebody else is saying, I have found even with arousal and orgasm, I don't get naturally lubricated, and my vaginal canal doesn't expand. Is there anything I can do to help with these physical symptoms? I'm ER/PR positive with bone meds. And she said before she had easy time with lubrication and sexual penetration, and can still get easily aroused and orgasm. So one of the things to do for vaginal dryness is use lubricants and moisturizers. There's a whole slew of them out there over the counter. The ones that appear to work best for a lot of my patients are those that contain hyaluronic acid, and then vaginal dilators, because that keeps the vaginal canal open and also helps you to figure out which way feels good, because not all ways of vaginal penetration may feel good to you, but there may be some that feel better than others. So those are the things that I usually talk to my patients about. Also, pelvic floor physical therapy can help, because there may be some contracture of some of these pelvic floor muscles, and that why penetration may be more difficult. But a vaginal dilator and vaginal lubricants and moisturizers will often go a long way. I saw something that somebody was talking about using a numbing gel right before sex. So yes, there is a 2% Xylocaine Gel available. Most of the times you will need a prescription for it. Somebody posted something in the thing that there's a 5% topical available on Amazon. I'm not sure that you can get it in this country without a prescription, but that sometimes helps. Applying lidocaine gel to the places where it hurts about 15 minutes before you have sex. And the other thing that helps is just time and talking about it and figuring out what feels good for you. Okay, let's go to the next slide because we have like a couple more minutes, maybe that. So vaginal dryness. So topical estrogens, as I said before, are topical estrogens safe if I'm hormone positive? As I said before, the amounts of estrogen in vaginal preparations are so low that they usually have no systemic effect. And so, one of the ways to maybe convince your oncologist who says all estrogen is the devil, say, can I try this for 3 months? And once a week, you check my serum estrogen. And if it gets into an area where you're uncomfortable, then at least we have the data and we can say, oh, yeah, maybe this is not safe for me. But if it's, if it stays in the postmenopausal range where you want me now, then maybe I can do this and my life will be a little bit better. Somebody was asking also about natural options. So there is a ton of vaginal lubricants, some silicone and some water-based one, and it's all personal preference what you want. For some people, silicone is too slippery, and others just don't want that. You can also use coconut oil, jojoba oil, or olive oil as lubricants or even vaginal moisturizers. They all work. How do you apply and how much of the natural moisturizers? So the over-the-counter moisturizers are usually low suppositories, and you insert them, I want to say, two times a week, every other to every third day. If you want to use stuff like coconut oil, jojoba oil, or olive oil, until you feel good. And you have to be the judge for that. Next slide. There was one more about birth control. So birth control option for those for whom hormones is not an option. So IUDs are an option. And somebody was asking, are men's birth control options covered by insurance? So for men, we pretty much have only vasectomies, and these are covered by insurance. We don't have any safe, reliable, and reversible male birth control. As I said, IUDs are definitely an option for most patients, ER positive, negative, or any of these permutations. The copper IUD is an option. It's good for 10 years. And for some patients, the levonorgestrel IUDs are an option after discussion with their oncologist. Again, usually the level of hormone that circulates in the general bloodstream is fairly low and should not interfere with the breast cancer treatment. But again, that's a discussion you should have with your gynecologist and your oncologist. We also don't want you to get pregnant while you're on all of these other treatments, because the options for choice have become severely limited in several states. Next slide. So this was an interesting question to me, because they were talking about dirty or not having clean ratings, which I don't know what dirty lubricants are. As I said, there's water-based and silicone-based lubricants, and a lot of that is a personal choice of what you want to use. Most lubricants nowadays are paraben-free, if that is the concern. And honestly, we have a list in our practice that's already outdated, because there's new stuff coming out all the time. So I would say look around and see if you can get samples, either from the drugstore or by directly emailing the companies and test them out. The other thing that I recommend some of my patients, go to an adult store, go to a sex store, and see if you can find a vaginal dilator, aka dildo, that works for you, and see what lubricants they have that work for you. I would stay away from the ones that have hot or warming in them, because they usually have cinnamon oil or some other stuff, which can make you hot in all the wrong ways. And so, don't be afraid to think outside the box and see what you can find, what would be more appealing to you. One probably last word. try masturbating by yourself, see what makes you feel good by yourself, and then translate what makes you feel good with your partner. And again, it's difficult to deal with this disease, and it's difficult even more to deal with the treatments and the surgical options and everything. So give yourself some grace that you've come through this, and give yourself, and talk to yourself in a kind way, and don't talk down to yourself. Think how you would talk to somebody who was your friend who was going through this, and then talk to yourself that way. Often I think we are our own worst critics, and are the meanest to ourselves. We say often to ourselves things we would never say to anybody else.
We are at the end of our program. We are out of time for additional questions. And I just want to say thank you so much. This was so informative, and I'm so glad we got to get to a lot of the questions. I want to let everybody know there is a link in the chat box. So please answer our evaluation. It really helps us out to evaluate all of our programs, and we will send a follow-up email, and the recording will be on our website and on our YouTube channel. Thank you again, Dr. Milbourne. We appreciate your time today.
Thank you. Thank you for having me.
Goodbye, everyone. Thanks for joining us.